good morning, everyone. My name is Nata. I'm going to be talking about the very controversial topic of targeted temperature management. Thanks to the procedure team. Thank you. A very special thank you to Dr. D'Souza for his expertise and his help on this lecture. Okay, so this lecture is actually mainly going to focus on post-cardiac arrest, TTM. So here are my objectives. So we're going to talk about the background, indications and contraindications. We're talking about the stages, complications. We'll talk about controversies and what the take-home points are from this lecture. Okay, so let's talk about definition here. So TTM, which is previously known as therapeutic hypothermia or protective hypothermia, it is the maintenance of a specific body temperature, like a goal body temperature, and then keeping that body temperature for about 24 hours. This occurs post-ROSC, after ROSC and post-cardiac arrest. We basically do this to improve neurological outcomes based off of a few studies that were published recently. So let's talk a little bit about background here. Who is that? It'll be a shame if you guys don't know who this is. Come on now. That's Hippocrates. So, so cooling actually dates all the way back to ancient Egypt. The idea of cooling a person can slow biological processes and subsequently death was first described by Hippocrates himself, who advised the wounded soldiers to be buried in snow in order to slow biological processes and death. Who was that? Who? Napoleon, exactly. So during the French invasion in 1800s, a battlefield surgeon noticed that wounded soldiers who were placed in warm campfires died a lot quicker than those who were placed in the cool bunks. They also noticed that people who were amputated, when they made them hypothermic or they used ice to do it, they bleed a lot slower than those who didn't use ice, who they didn't use ice for. I highly doubt that you guys know who this is. This is Temple Fay. He was a neurologist and a neurosurgeon. He published the first scientific paper relating to therapeutic hypothermia. His focus was mainly on TBI. And his paper basically published that when temperatures were lowered from 38 to 32 degrees Celsius, there's improved neurological outcomes in patients with TBI. And then in the 1950s and 60s, they started using very deep hypothermia. I'm talking about in the low 30s, 29. As you can imagine, that was abandoned very quickly because people started dying. And then in the 1990s, mild hypothermia was implemented in 3 cardiac arrest after successful resuscitation. All of these patients made it out with no residual neurological damage. And then in 2002, we had these 2 trials that came out that actually put a little bit more attention into the topic. This is the HACA trial and the Bernard trial. Both of them were published in the New England Journal of Medicine, and they were found that significant improvements in short-term and long-term survival, as well as neurological outcomes in patients who were cooled. So, going more into the background. So, TTM supposedly, it improves neurological outcome and decreases mortality through multiple mechanisms that alter the cascade of the metabolic, cellular, and molecular changes following global ischemia. So you have cardiac arrest, then you have lack of perfusion, you get ROSC, you have reperfusion. With that reperfusion comes increased metabolic demand, you get increase in free radicals, release of excitatory neurotransmitters, and inflammatory products which cause apoptosis in the brain. So through that mechanism, you get decreased cerebral metabolism. So for every 1 degree Celsius to cool the patient, you get 68% decrease in cerebral metabolism and demand. You get a decrease in excitatory amino acids such as glutamate, You get a decrease in oxygen free radicals. You diminish inflammatory products and cytoskeletal breakdown. So what are the indications for this? Based off of the American Heart Association, so out of hospital cardiac arrest with the initial shock rhythm, this is a very strong recommendation, but it has a low quality of evidence. You have out of hospital cardiac arrest with an initial non-shock rhythm. This is a weak recommendation and a low quality of evidence. You also have in-hospital cardiac arrest with any rhythm. This is another weak recommendation and weak quality of evidence. Also, the patient has to be comatose. Whether it's GCS less than 6 or 8 is institution dependent. So let's talk about contraindications. There aren't really, all these contraindications are relative because they're all pulled from the trials that were done and published. So you don't want to do this in a patient that's responsive. You don't want to do it in a patient that has uncontrolled bleeding or life-threatening coagulopathy, cardiac arrest due to trauma, DNR. Other relative contraindications include a prolonged cardiac arrest, so longer than 60 minutes, or a patient that has refractory hypertension despite pressors, or a septic patient. These are now universally applied. So every institution that you go to is going to have different contraindications and indications for cooling a patient. So just to give you an idea, this is Downstate's inclusion and exclusion criteria for cooling. So kind of like the same things I've talked about, some of the exclusion when the GSS is greater than 8. Here they mention a patient with a poor functional status, which makes sense if you have life-threatening bleeding, a traumatic arrest, and such. Okay, so next let's talk about the stages of actually cooling. So you have the initiation phase. This is a phase where this is kind of like more pertinent to the ED because we usually start the initiation phase. So the cool target temperature is between 33 to 36 degrees. I'll talk a little bit more about why that is. It is institution dependent and it's supposed to happen within 4 to 6 hours post-ROSC. You have the maintenance phase. So you stay at that temperature for about 24 hours. And then the rewarming phase. So you gradually increase the core temperature to normothermia. So between 36 to almost 38 degrees Celsius. So let's start with the initiation phase. So this is the phase, like I said, you cool the patient or start cooling the patient and your target temperature should be between 33 to 36 degrees Celsius. There have been different trials. So the TTM trial, which happened back in 2013, says that there's no difference in mortality between these two temperatures, like 33 and 36. Whereas the Hyperion trial, which was published back in 2019, looked at patients with non-shock rhythm, and there is a survival benefit, and they tend to have a better neurological outcome. It was statistically significant in 33 degrees. So patients with post-ROSC non-shock rhythm, there is benefit in cooling them to 33 degrees rather than 36. There's also some like committee on resuscitation, like the international liaison, that recommends patients who have a history of like bleeding, GI bleeding, you should cool them. Target temperature should be 36 degrees rather than 33. Okay, so let's talk about initiation of cooling. So you have conventional and surface cooling. These include, so you have ice packs. You can use ice packs on areas that are anatomically large areas where you have a large heat exchange capability, like the head, the neck, the axilla, and the groin. All you do is just take ice packs and put in these areas. And then when they start to melt, you remove them and you replace them. You also have cooling fans and cooling blankets. So these methods are, readily available. They're inexpensive and they are appropriate to initiate cooling. The only problem is they are very labor intensive because you have to put them on, replace them. They often result in temperatures that are lower than the target temperature. And they are not very effective in maintaining a target temperature. So once you start it, you might cool the patient a lot faster and a lot lower than you want them to be cooled. There are other guidelines for actually induction, such as giving cool ER, standing Tylenol, starting the patient on paralytics, such as Nimbex. I'm not going to go into details about that. Every institution has a guideline, so you can just look at the guidelines. The other option is core cooling, which we do have downstate. So what I found is that we have it on both sides of the street. A downstate, you can initiate it in the ED. So this consists of placing an intravascular catheter into a central line. So this catheter, it circulates cold saline. They have a high cooling rate, so between 2 to 4.5 degrees Celsius per hour, depending on the size of the catheter. I believe at downstate, we have the Solex, which is the very last catheter, the one with the coils. And we have the capability of actually placing them in the ED. So these are considered very reliable in all three phases of hypothermia. They do have their disadvantages though. One, they are very invasive because you're placing a central line. There is a possibility of catheter-related infection and thrombosis, although they are very low. They're also very expensive. They require a very high level of monitoring. They're labor intensive. It's not ideal to start this in the ED. So you can put the catheter in. Of course, you're going to need the MICU. Ideally, you want to transfer the patient upstairs where they have nursing and everything available in order to do this. So let's talk about the maintenance phase. So the maintenance phase is once you cool the patient to your target temperature, whether it is 33 degrees or 36 degrees, you want to maintain that temperature for about 24 hours. So how do you do that? We have temperature probes. The one at the very top here, that's an esophageal thermometer. This one goes in the Foley. This is a bladder, and that one is a good old rectal probe. So you can use all of this to measure temperature. So the gold standard is actually using a pulmonary artery catheter, but nobody has time for that. So we use the bladder, the rectum, the esophagus, or tympanic. There is a time lag in all of these. So the registered temperature is not going to be the same thing as what is measured, especially during the induction phase, because you're lowering the temperature quite fast. This may lead to overshooting. But what we use for the most part is going to be the esophageal thermometer. It is the most rapid and accurate reflection, and it is currently the gold standard. The average lifetime is about 15 minutes between what the body temperature is and what is recorded. So it's not that terrible compared to everything else. So during this time, during the maintenance phase, you also want to start medications to prevent shivering, because shivering is going to kind of just erase everything that you just did. So you want to start the patient on maybe standing Tylenol, you want to do fentanyl, propofol, you want to paralyze the patient. And then the last phase will be the rewarming phase. So this is when after you've done your maintenance for about 24 hours, you want to gradually increase the core temperature to normothermia. So how you do this is you gradually increase the temperature 0.2 to 0.5 degrees Celsius per hour until it is greater than 36 degrees. If you do it too fast, you're going to negate the benefits of therapeutic hypothermia. And then when you reach 36 degrees, you can remove all the cooling devices and the medications that you were giving to prevent shivering. This takes about 12 to 24 hours. Of course, usually this happens upstairs while the patient is already in the NICU. It can take up to 8 hours. If you're cooling the patient and they develop like severe dysrhythmia or bleeding, you need to rewarm them immediately. You do not need to wait the entire 24 hours. Okay, so now let's talk about the complications of actually cooling someone. Hypotension, bradycardia, and arrhythmias. These are well known in anyone who is hypothermic. So you may run into these issues. These are easily fixable. You can start pressors. If the patient needs pacing, you can pace them, or rewarm them if it becomes life-threatening. You get decreased oxygen requirement because you have decreased metabolism. You have decreased oxygen requirement. What you can do is adjust the vent to an SpO2 of 95% and normal cardia. There's something called cold diuresis, where once you start cooling the patient and they start diuresing. So you can do like standing fluids to kind of prevent that from happening, monitor the eyes and nose, and maintain euvolemia. Another thing that can be really concerning is electrolyte abnormalities, especially hypokalemia. So you need to check the patient's electrolytes Q2 to 4 hours, depending on what institution you're in, and replete the electrolytes. You can also get hyperglycemia due to decreased insulin production. So you need to monitor the blood glucose. Targets should be between 80 to 180. You may need to start continuous insulin infusion if this is a problem. These are some more complications. You need to put an OG tube in. There could be coagulopathy, which is why patients can bleed from this. And there's decreased drug metabolism, so keep that in mind when you're starting medications. So with all that being said, you can just imagine how labor intensive all of this is. We do still do cooling at Downstate. It's come up once during my shift, it's come up once before. We ended up not cooling the patient for other reasons, but it's come up several times. But then the question is, are there like what does the new evidence show? Are there any benefits to actually cooling someone? So in June of 2021, the TTM2 trial was published. This is very recent. It was a randomized control trial. It was 1,800 patients, targeted hypothermia 33 versus normothermia, which is 37.8. They actually found that there is no benefit of targeted hypothermia in improving survival at 6 months. This is the largest study that's been published so far. It's a very strong study because both groups were treated similarly. Mechanical ventilation, sedation, and neuroprognostication was performed using a standardized protocol. So this study, which was very recently published, says that there is no survival or neurological benefit in cooling patients. Just bear in mind, they only studied patients who were out of hospital cardiac arrest. So this doesn't apply to patients who are in hospital cardiac arrest. A lot of their patients, like 90% were witnessed, and about 80% got CPR. So keep that in mind and see if it applies to your patient. But it is a very strong study, and people are looking into it. So with that being said, in this newest study, is there anyone in here who would still cool a patient if, for example, if the MICU calls you and tells you we should cool this patient? Is there any change in your practice given the newest guidelines? Seems like the consensus is no. So
I guess the issue here of not like it's not saying don't do anything, so right? So avoiding fever is
right.
important. So the concern is that you start saying, well, all right, now I don't do anything, just walk away from the patient. Is that maybe these patients are gonna have worse outcomes because they're not getting the nursing needs, and maybe they're gonna have not getting temperature monitored. So I'm not sure. Takeaway is that at least in media, I think one for folks to be like, all right, I don't do anything since the ICU. Work there for 12 hours. Maybe they won't have a temperature monitor. So theoretically, there's still benefit of at least having temperature monitored. So I don't know. For me, there was no downside to it, right? So there wasn't like an increase in the health. So that's my concern. What is resource review?
I'm sorry.
Increased resource utilization.
Right. And you can also run into, although they are very rare, some of the complications of actually cooling someone. So I do agree. I think the main point in this study is preventing hyperthermia, preventing fever in patients who are post-cardiac arrest and patients who you have ROSC, and maintaining normothermia. So you should definitely monitor temperature, prevent fever in this patient, but should you still cool the patient to 33 degrees, for example? Like, is that still indicated? So just something to think about. I know it's quite new, basically for the future. So these are some of my take-home points from this lecture. So TTM is recommended by the AHA in post-cardiac arrest of any cause, the GCS less than 8 or 6, which is institution dependent. Inclusion and exclusion criteria are also institution dependent. There are 3 phases. There's initiation, there's maintenance, and there's rewarming. Surface cooling, it's less expensive, it's less invasive, but it's also less reliable. And then the core cooling is more reliable, but it is more expensive and it is more invasive. Complications are rare. If they are life-threatening, of course, you should warn the patient immediately. And then there is a new large RCT that found that there is no survival benefit at 6 months and there's no difference in neurological outcome. And then hopefully, maybe, questionably, guidelines for cooling are soon to change. And that's about it. Do you have any questions? Dr. Silverberg.
I think the fact that every institution does something different and like it's iffy sort of suggests that probably is not great and doesn't really work. I mean, to say that because there's no downside we should do it, I think it's not a great argument for it just because it does waste resources. If it just has no downside, why not do it? Also give it vitamin C and wave chickens over their head. I think you need some sort of data to show them.
So Dr. Silverberg is saying that because every institution does something different, it may be an indication that it doesn't really work. It utilizes a lot of resources for something that basically is questionable. Yes, Dr. Willis.
No, downstate, but still like catheters were supposed to be covered by attending senior residents. So I'm not sure what the policy or county is be aware of.
I'm not sure at county if we actually put in, I don't think we put in cooling catheters in the ED. Yeah, they do it upstairs.
There are catheters,
Yeah. Yeah, we have the blankets and everything. We don't have the catheters. And yes, at downstate, only the attending and the senior residents are allowed to put in the catheters. So
You know, EMS still gives cooled saline in the field. They stop that.
they stopped that. They don't do that anymore. And the AHA actually recommends against starting cooling in the pre-hospital setting. So they don't do that anymore. Yep. Okay. Any other questions? Awesome.